It's my pleasure to introduce Dr. Fagan. I've had the pleasure of working with over the last number of years and built a really nice collaboration. I think he's going to talk a lot about that and other collaborations he's developed. So Dr. Fagan received his undergraduate degree in exercise science from the University of Southern California in 1989, graduated from Baylor College of Medicine. He followed the completion of his residency program at the Bakey Department of Surgery at Baylor College of Medicine, and went on to be a full-time faculty member there. His interest in critical care medicine resulted in a surgical critical care fellowship at the University of Texas Medical Branch in Galveston. Outside his clinical interest, Dr. Fagan is also interested in research, specifically in microfluidics, as well as telemedicine, which he'll be speaking about today. He joined the Division of Burns in 2006 at the MGH and was named the medical director of the Sumner Redstone Burns Center in 2008. So it's my pleasure to introduce Dr. Fagan.
Great. Thanks, Tim. Well, I really appreciate coming over and talking on a subject that I'm very passionate about. I hope by the end of this, being involved in research and being involved in clinical medicine, I think there's few times where you really think that you've hit on something that's going to make a big difference. And certainly while I'd love to tell you that microfluidics and studying neutrophil migration is going to have a tremendous impact on medicine, I think the utilization of telemedicine and forming collaborations across distances, great and small, is really where we need to move. And I think if you think about what we're doing right now is we're teleconferencing this education system. So, when you think of telemedicine, usually people say that most of the people who work with me say that I don't speak softly, so sorry if I didn't lean into the mic, but please raise your hands if you need me to speak up. But anyways, I think that it just shows you where telehealth really is starting to slowly find its way in, and one example is just this conference today. So what I'd like to do today is just share my experience with establishing the MGH TeleBurns program and why we did it. And then some of the applicability of telemedicine to the rehabilitative phase. And if you're over at the MGH, I always say that I have the easy job when it comes to the treatment of burns, is I just get the patients well. But the real work becomes with our therapists and our support staffs and really getting these people back, because, the LD50 now for burns is about a 92% burn. So, 50-50 chance of living or dying with 92% of your skin needing to be replaced. But it's not just about replacing skin, and I think the wonderful work that you guys have done here demonstrates that, in that the real goal is to return these patients back to the functional capacity that they were before the injury. And I think there's some great work in terms of functionality, and then some neat work with regards to cosmetics too, that is just revolutionizing what we do. So my disclosures, I don't have any, other than you can sort of tell that I'm very passionate about telemedicine. So I might try to lure you into the telemedicine is the next great thing. So I think anytime that we start off a talk, you got to understand the definitions, and the Joint Commission established the definitions for both telehealth and telemedicine. And telehealth is the use of electronic information and telecommunications technologies to support long-distance clinical healthcare, patient, professional-related education, public health, and health administration. And so this conference today is definitely a demonstration of telehealth, because we're doing that professionally health-related education over distance. Telemedicine is the use of medical information exchange from one site to another via electronic communication to improve patients' health status. Obviously, therefore, telemedicine is just a subcategory of telehealth. Now, who thinks that they've actually done telemedicine already? I guarantee you that everyone in this room has actually done telemedicine, because utilizing telemedicine, like we're going to talk about today, in video conferencing, which is, I think, the Cadillac of telemedicine, but certainly sending messages, clinical information about patients over your phone, right, or emails, or actually even talking on the phone, is a form of telemedicine. So I think what we have to do is encompass all the different modalities, and there's not everything needs to have a camera that I can control with 2 screens in terms of video conferencing. That a lot of work can be done with much less sophisticated devices. And the real trick with telemedicine that I try to explain to the residents is that it needs to be HIPAA compliant. And then there needs to be forms of documentation that both sides of the communication have for their references. So I like history, and I was fortunate to work with some fairly knowledgeable people in surgery. I think you heard Dr. DeBakey. He was my first doctor that I ever got to work for, who invented cardiac surgery. And then there's Dr. Maddox. And Dr. Maddox had profound influences on the treatment of trauma and still does so. But as a young surgeon, when we thought that we were fairly intelligent and fancy, and we'd come in and we thought we invented something new in terms of surgery, he would simply remind us that we probably haven't looked in the history books long enough. And at that time, I think some of you in the room might remember that PubMed only went back to 1967. And so he reminded us that medicine actually existed before 1967. So if you only searched to 1967, you probably weren't doing a very good job. So anyways, I think this is a very important part of medicine to understand where it came from. And so I'd like to give you a brief history of telemedicine. And telemedicine actually celebrated its 100th anniversary in 2006. The term itself was coined by an American, a Dr. Thomas Bird. And I think how you translate it is what we're doing. And that's just healing at distance. And I think that was a wonderful term to utilize. And then there was this gentleman, William Einthoven, who actually performed the first telecommunication. And he was a Dutch physiologist, and he was the first clinician scientist to develop and systematically apply telemedicine. He had developed the first electrocardiograph, for which he won the Nobel Prize. And while he was in Holland, he linked a hospital to his laboratory via telephone wires and a string galvanometer and his electrocardiograph. And he could actually interpret the results in his laboratory and then send the results back to the hospital. And so this was the first demonstration of actually telemedicine being applied. And this was back at the turn of the century. And I think this quote by him sort of sums up what the ambition is with telemedicine and why we do it and why there's a drive to do it. And so he made this, I think, very nice statement where he said where there is a link, actual or figurative, between laboratory and hospital. Remember, he was a physiologist. And a collaboration between the physiologist and the clinician, each remaining a master in his territory, there will be fruitful utilization of these new electronic methods of research. And so I want you to remember that because there's some key phrases in there. One of them is a link. So telemedicine, you're linking to areas. Second, a collaboration. I can't tell you how important it is to have a collaborative effort because you need people who are passionate on both sides of the communication. If there's only Dr. Fagan who's passionate about it, doesn't matter because nobody's reaching out for Dr. Fagan's opinion. But if there's someone passionate on the other end of the communication spectrum, you have a very fruitful relationship, and I think it bodes well in terms of how we deliver medicine. And the other thing is, remember that it allows people to stay a mastery in their own territory. So you never want to link somebody. Why would you link a tertiary care MGH to Tufts? Now, I understand that I'm from the MGH, and everybody would say, well, that would just seem obvious, right? But realistically, if you're a tertiary care hospital, why would you be linking a tertiary care cardiologist with another tertiary care cardiologist? Maybe for education purposes, but probably not for the delivery of healthcare. Well, here, I think we'll show you that linking the burn expertise with the rehabilitative expertise, i.e. two masteries, and bringing those two together in one location, although separated in a distance, has been seen to be very fruitful. With regards to MGH telemedicine, Everybody's abuzz. Oh, MGH is trying to launch a telemedicine program. It actually started back in 1968. And it was actually a link between MGH and Logan. So it's not MGH trying to link with northern Maine or northern Vermont or northern New Hampshire. It was through a tunnel to the Hobby Airport. And they actually had a lot of services at that time. And interestingly, a lot of the services that MGH Telehealth is now moving forward in terms of their rollout. And one of them was teleradiology, and certainly radiology, if you haven't noticed, they read films from all over the place. So they are well advanced in the field of telemedicine, telecardiology, teledermatology, telepsychiatry, very large program at the MGH actually, and then television microscopy, otherwise known as telepathology. So for roughly 8 years, they did over 1,000 consults, fairly high quality telemedicine services, and you could walk into a clinic in Logan and link with the MGH if you had a problem, or you could actually get help if you're on the airplanes in transit. Pretty neat program, and it was only 2.7 miles away, and I want you to remember 2.7 miles because I think it's important, because telemedicine, everybody thinks that you have to link long distances, and that was actually said to me when I started some of my programs, and I'll tell you that it can be down the hallway as long as it makes you more efficient. Other interesting things, and this is back in the 1960s, is the technology wasn't exactly HD, right? We didn't have flat screens. This is microwave technology, but more than 70% of the people participating in the program felt that they achieved the same levels of satisfaction as if they were sitting in front of the physician in an office. You know, more comfortable or as comfortable. Sounds like a topic we're going to talk about. But so when you have somebody that feels it's the same, then there's a potential that it'll move forward. Obviously, if they feel that is less of a service, then they'll probably maintain the historic way that we see patients. So why did it go away? Because it did go away, and there was a resurgence led by Dr. Lee Schwanz with telestroke, which he's done a fantastic job with. Well, to have a successful telemedicine program, you need to have a patient service, which is equivalent to in-person service in terms of effectiveness. And this includes not only the patient, but the provider. Because if either one of them doesn't believe in it, then it's not going to move forward. It needs to be sustainable, right? 8 years. It needs to be cost effective. I think we'll show you some data today that it's extremely cost effective. And then the service needs to migrate into the mainstream of healthcare delivery system. So it has to become a way that we actually practice. And so why did it disappear? Well, a little bit was due to marketing. So they definitely, I think 70% is reasonable. I think the data is better now, but it's reasonable that people felt that they were getting the same level of care. The second thing is it was sustainable. 8 years this program went over. 1,000 consults. I think I'll show you our program, which is much smaller than the cost savings. 1,000 patients, amazing cost savings that were probably occurring at that time. But the problem was it wasn't part of mainstream healthcare. And one of the reasons is because when they were doing this, where were we? We were going to the moon, right? So where they visioned this technology is how could we provide healthcare to the astronauts? Anybody met an astronaut? I guarantee you they are not the people that need healthcare, right? Highly intelligent. Most of them probably are doctorates or have their doctorate degrees, right? And then extremely physically fit. But that's where they went with it. They went with it to say, we're going to use telemedicine to bridge the space, not bridge 2.7 miles, the MGH to Logan. So it went away. So TeleBurns, my adventure. So why did Dr. Fagan get interested in TeleBurns? Because I actually didn't get assigned it. I actually thought this was where we needed to go. And there were several drivers. As the medical director, I get to get a lot of emails, and I get to go to a lot of conferences about how we can do care better. And so one of the biggest drivers, I think, to telemedicine is that we're moving how we measure quality of care. So especially in surgery, I can only speak of surgery, but we used to be volumetric in terms of measurements of quality. Dr. Fagan does 1,000 burn cases a year. He has very low morbidity and mortality. Great place to get your burns done. But we never ask the patients, do you like Dr. Fagan, or did you like your care going through? It was all about numbers and complications, and that's how we measured quality. But a little while ago, we changed. And now we're measuring quality not only on those volumetric standards, but on perception and on how the patients perceive their care, not how we're perceiving it. And so one of the things, I don't know if you guys get to do this, but we get HCAP scores. And so HCAP scores are a standardized survey instrument to patients' perspective of their hospital course. And the goals when they initiated this program was to produce comparable data between hospitals because, you know, we always take care of sicker patients, or our patients are different, and that's why our numbers are different. And so they wanted to try to make things equal across all the hospitals. They wanted a public reporting system, so this data is released to the public, right? So that there's an incentive to change the perception of how you are providing care. And then they wanted to enhance the public accountability in healthcare, increasing the transparency and quality of hospital care. I don't know if that was the main one. I think number 2 was really important, that they needed something to make people change, and releasing data to the public certainly catches people's eyes. So this is just one of the things that I get all the time. This is an HCAHPS scoring, and you can see that they grade us on multiple things. Nursing communication, doctor communication, is the place quiet at night, is the food good, all these different things. And you can see that this is the next paper I'm going to write, is that it's okay to be read, because it's really hard to get people's perceptions in link with what we want to deliver. The other thing is how you have to get a non-red box. It has to be always. So how they write the survey is there's always and almost always. Well, I don't know about you, but when I take a survey, it's pretty rare when I say always. So the standards are extremely high. You get red boxes, and you need to make the red boxes into green boxes. So this is just one of the drivers. How do we make patients' perception of care better and make it more efficient for them? Again, they don't just look at us inside the hospital, they look at us in our clinics. And you'll see how this rolls right into one of the programs that I'm very proud of in collaboration with this facility here, and this is the CGCAPS. So CGCAPS is the Clinical Group of Consumers Assessment of Healthcare Providers and Systems. I think I'm just going to remember CCAPS. And it's a standard tool to measure a patient's perception of care delivered by provider in the office setting. And as of 2012, if you had over 100 providers on one tax ID number, you needed to collect the survey information, and it too becomes public. So one of the things that they do, amongst many, and they're very similar to HCAPS, but CCAPS are very similar, but one of the things that was of interest to us, and I went to a meeting, and I'm actually the safety and quality director for the division of burns, and so I don't know if you've ever been to a safety and quality meeting, but every once in a while you get a lot of red boxes, and you're frantically writing down, how do I improve this red box? So this day actually was a good day for me, because this slide came up, because they were measuring access to an acute care appointment. The goal being they wanted all patients to have appointments by 2 weeks. And as you can see, outlined in red, we're one of the best in the Department of Surgery. We actually have about a 1 to 2 day wait to see a new patient in our clinic. So I'm rocking back in my chair, and I said, oh, I have a moment of peace, right? I don't have to do anything until the next slide came up. So then the next slide came up, and they said, well, what's the perception of getting that appointment on time? Well, as you can see in red, I'm one of the worst in the Department of Surgery. Only 71% of the people felt that they could get an appointment urgently. Now, how's that? Well, the real reason is because when you have a burn and it hurts and nobody knows how to treat a burn, you want to be seen that day. And so even though we were seeing patients within 24 to 48 hours, their perception was that wasn't good enough. And probably us, and I know how we do things, saying that, well, you can just come to the MGH ER and we'll be happy to to see you, what do you think that perception was? Really bad, right? So you can see that what we think in terms of actual practice and our perceptions and patients' perceptions don't always match. So we have to sort of think on the patient's behalf on how can we make it better for them. So there's some other drivers that got me into this. We have a very large clinical catchment area. We have one of the largest at the MGH. We span all the way to the Canadian border, Vermont, down to Rhode Island. So we get burns from all over the place. And unfortunately, and I think as you guys sort of know, there's not much education about burns in the community. So when someone gets a burn and they roll into an ER in northern Maine, they just want to get the patient to an expert. And unfortunately, if that's a 6-hour drive, it's okay. What's unfortunate is when I walk down to the emergency center, I look at the patient and I say, you'll just be fine, put some salve on it, you can go back home. How am I supposed to have good perceptions of care when the patient comes 6 hours? I've spent 10 minutes with them, and now I got to get them back home in 6 hours. So again, not great health care that we're providing, and certainly we could provide the same level of care, I think, via different options. Market share, with the advent of telehealth and telemedicine, there are no boundaries any longer. So, you know, if you look at the partner system, right, say, got Boston pretty locked up, right, maybe even Massachusetts. Well, not so much, because I went to give a talk down in Fall River, and I walked through the doors, and I think you heard that I trained down in Texas. I actually got to rotate to MD Anderson, fabulous facility. Number one. Number two, they battle back and forth in terms of the best cancer center in the United States. And I walked through the door, and in the Fall River Hospital, it says, we link with MD Anderson for our health care. So that's interesting. Once a week, they have a teleconference with the MD Anderson folks about all the cancer patients that come into Fall River, actually to a healthcare system down on the Cape. So they didn't come to Boston for their expertise. They didn't go to Sloan Kettering in New York for their expertise in oncology. They linked all the way to Houston, and they can do it very efficiently. Another example nationally, Connecticut hospital system linked with Arizona for the providing pain management. So you can see that the turf of areas have been completely destroyed with telemedicine. Because as long as you can provide the link, the collaboration, you can bring masteries of medical services to anybody's doorstep. And obviously internationally, you can do this as well. Access to care, one of the big, so the American College of Surgeons, for which I am a member, one of the big things that they're moving is that everybody has the same access to care with regards to the treatment of their surgical conditions. And you can tell there's 70 burn centers in the United States. We are the largest. There is not a burn center verified in Vermont, New Hampshire, Maine. So how do you provide access to that care when the majority of states in the Northeast don't have burn centers? And then finally, you know, I totally believe in that you have to change to stay ahead. And while I'm very proud of the MGH, it has a fantastic legacy with regards to treatment of burn care. If we don't continue to advance things through research, if we don't continue to try to do things better, we will be left behind. And I actually saw this occur at Baylor College of Medicine. It's not a fluke. If you don't change, even if you're really good at something, people want the newest and the greatest. And you have to be willing to change. And so I was interested in just seeing if we could deliver healthcare in a different way. And I specifically wanted to do it because it's no fun telling someone that they can go back home after they just spent 4 hours in an ambulance coming to see you. And so that doesn't make for, obviously, a great day for the patient and not a great day for me. So I knew there was a better way we could do this. So we put together a team. I was very fortunate that Dr. Lilimo, the chairman of the Department of Surgery, endorsed this. My then chief, Dr. Tompkins, was fully supportive. I was the clinical champion, and then certainly I couldn't have done this without my administrative help. And Ty has been, continues to be fantastic in moving this project forward. So when we decided to do this, we wanted to make a collaboration with MGH Telehealth because MGH Telehealth was launching and we wanted to be one of their projects. And so we wanted to line up our vision with theirs. And there's two areas that we were particularly interested in and moved into their objectives and goals. And one of them was referral management. And this was to provide community providers and patients with specialty consultations. So that seemed very obvious because we just talked about that for the last 5 minutes. Which will keep the patient in the community and only bring the appropriate level of care to the MGH. So that was one of the goals that we set out to do in terms of a pilot project. And the second one was regards to this term called population health management. And with the Affordable Care Act, this will become more and more of a term that you will hear. But this is for MGH patients or partners patients to provide high quality of care, but to provide efficient and effective care without wasteful spending of healthcare dollars. So we launched a couple pilot programs. We had our referral management. We talked about that. How can we link with the outside and provide consultations in somebody's home or local community without having to come all the way to the MGH for that care? Virtual visits, population healthcare management, one of the biggest aspects of this talk is going to be linking an MGH provider with a former MGH patient who happens to reside now in the Spaulding Rehabilitation Hospital. And then finally, and not one of our big things, but certainly something that we can do is virtual staffing, where an MGH patient can be seen by an MGH provider who happens just not to be at the bedside. And probably the best group that has done this is the MGH PICU, where they actually provide all the care at night to the PICU through telemedicine. So the attendings link with the PICU if there's a problem in the PICU, and they can provide real-time advice to any PICU situation with the fellows in-house. And it's been a fantastic program because obviously the acuity in a PICU fluctuates. Extremely expensive to keep a physician in hospital 24/7 if you're not needed. So this allows them to have a very flexible program and to meet the needs of the acuity on a second's notice. So with regards to our referral management program, this is providing our specialties to the community. The first thing we want to know is where should we go, right? So this is a hub and spoke model where we didn't need to be in every hospital. We just wanted to be in various regions so that people knew if you got a burn, you go to that hospital and you can link with the MGH. So we did an analysis, and one of them was based on where our patients come from. So the lower map just shows you the pockets of where patients refer in from in inpatient and outpatient care. We also knew Dr. Lee Schwam's program, the Telestroke, they have an extensive, I think it's 28 hospitals that they link with. So they had a network of hospitals that they had already linked with. So that was really convenient because those hospitals already had the hardware established that we could piggyback onto. So much less of an ask to an outside provider if they have all the technology within their hospital. It's just activating another line of care, not trying to bring not only the care in, but also the hardware. And so, as you can see, there's this area out in Western Massachusetts where we get a lot of patients from, and we felt that would be a good place to tag for our initial referral management program because this is a 3-hour drive. And while I mentioned the 6-hour drives, we get plenty of 3-hour drives from the western part of the state looking for care. And so, coincidentally, MGH, I don't know if you know this, partnered with Cooley Dickinson, which is one of the hospitals out in the western part of the state. And so they had already established a telestroke program with Lee Schwam's. And so we started a ED evaluation of acute thermal injuries, frostbite injuries, degenerative skin disorders with them. And I have to say that this program is a little slow to get going, and I have to say is because, one, we have to educate the staff, so make the staff comfortable, but then we have to re-educate the entire community because the referral patterns for burns in the western part of the state does not come to Cooley Dickinson. it goes to Springfield generally, trauma center, not a burn center, but a trauma center, and they link to us. So we are trying to slowly educate the EMS in their system, if appropriate, and you don't need level 1 trauma, which would still go to Springfield, that we have this program that perhaps we can keep people in the community and avoid these big time transport costs into the city, which not only impacts the healthcare system, but and a lot of times impacts the persons directly. We would like for this program to expand into wound care. Anybody who has worked in a hospital knows that having doctors see patients with wounds is always a challenge. We sort of specialize in wounds, so we'd love to expand those services. And then really, and I think it's germane to the topic that we're going to get to in a second, is really following up our patients postoperatively. So when we send a patient back to the western part of the state, can we refer them into Cooley-Dickinson and link with them so that they might have to drive 30 minutes, 45 minutes to Cooley-Dickinson for a postoperative visit versus the 3 hours into the MGH to see us in postoperative care. As I sort of said, there has been limitations not only in education and referrals in the state, but also, unfortunately, our legislatures have not caught up with the technology or I guess the passion of certain individuals like myself in that they don't allow us to bill directly to the patient. Now, they do this in Arizona, they do it in the South. We're just a little, I think, cautious or conservative, I guess is the right manner, right, in the Northeast, about allowing a physician to actually provide consultation at distance with all the proper documentation and be able to bill as if the patient was in our office. We know this is completely the same. It's just our legislatures striking a pen and allowing it to happen. So the growth is slow, and a lot of it has to do just with reimbursements. That being said, these programs can be highly effective. Probably one of the best programs with regards to telemedicine, with regards to burns, is a Utah program. And in 2 years, they brought in $4.1 million to the hospital with their program. So it's not huge dollars, large enough dollars for me, but hospital administrators, they think in much larger terms. But that certainly makes a cost-effective program when you're bringing in $2 million a year. I can tell you that the licensing fees for telemedicine is substantially less than that. So let's move on to the program that actually I'm very proud of and actually I think is the best and brightest program with regards to telemedicine, and that's our population healthcare management, or our partnership here with Spaulding. So I want to tell you a little story real quick. And the story goes like this. So I'm sitting in that safety and quality meeting again. And all of a sudden they say, we need to reduce readmissions. I said, okay. And that's the first time you actually see what your readmission rate is. But it was really nice because they broke it down. They said, well, where do you think your readmissions are coming from, Dr. Fagan? I said, I have no idea. We have interesting demographics, all different things. But interestingly, greater than 50% of our readmissions were coming from rehabilitative hospitals or those patients that were receiving home nursing care. So that struck me odd. I'm sending patients to facilities that obviously can provide a higher level of care, yet this is my highest area of readmissions. So we sought to fix this, and we partnered with a lot of the home nursing care places and brought them into our clinics and provided education with regards to our wound management and how we do things, because we felt that it could just be an educational thing. And while I can't reach out to every rehabilitative hospital, I could reach out to one, because Dr. Snyder, well before I came here, had developed a program with the MGH where they were trying to and have established an expertise in burn rehabilitation. So I knew a fair amount of our patients were coming over here to Spaulding, not all. Obviously, insurances get in the way of where we'd like to send patients. But I knew that there was a fairly large amount that were coming over here. And so I said, well, how can we make this better? Well, at that time, Spaulding was really close. In fact, it was only a mile away. And it was really nice to get out of the MGH and you could walk by Pachi's and grab yourself a drink or something as you walked over to Spaulding, and unless it was raining or snowing, it was about a 20-minute commute there. And so Dr. Governman, who actually led this program up, got privileges here, and he was walk over, and once a week he would see when we had patients at Spaulding and see them once a week and try to communicate with the attendings and the various people that were working, primarily the nurses, because again, we weren't really matching times because we'd probably come over after 4 or 5 o'clock. And so we were speaking a lot with the nurses, but I think the program was still in its infancy and we weren't really communicating with the physicians directly, and it just had to do with time. So we wanted to improve the care model. The program was very successful, and in fact, I think, Jeff, correct me if I'm wrong, it got a Partners in Excellence award when we were walking over. So we were sort of doing home visits again. I have to say that not only did the patients like it, but the providers liked it, because Dr. Governman loved going over and seeing the patients. We knew how much better it was for the patients because that 1-mile trip was a disaster for them, especially our larger burns, uncomfortable stretcher, in our clinic, off a clinic gurney, back on a clinic gurney. If the ambulance didn't stay, they had to stay on our little exam table until an ambulance came back. It doesn't take much understanding of what was going on to say that this was just much better, us coming over, seeing the patients in their own beds, and the patients not having to come see us at all. And certainly we knew that was saving healthcare dollars globally. So then we opened up this wonderful facility that we're in right now. And while a fantastic facility, the only problem is it took that less than a mile, and it made it 2.1 miles. Now a little less than Logan Airport at 2.7, but it was 2.1 miles. And really what that did is not only did it double the distance, but it doubled our time to get here. And while you can probably do it a little quicker, it took us 20 minutes to walk over to Spaulding back and forth on a leisurely pace. To get here via the shuttle, it's 40 minutes each way. And so that started impacting the program. Well, to be truthful, I had this sort of vision, and it was prior to you actually opening up this fantastic building, that I still felt like we could save time if we could do these appointments via telemedicine and save that 20-minute walking time over to Spaulding. And I'd have to tell you, my partner was totally against it. He was like, I like walking over, I want to see patients, I don't want to do it via telemedicine. And I said, that's great. So you guys opening this new thing gave me a little more push to have him embrace it. And there was a lot of other things that came into alignment at the same time. I think you all were looking to link with MGH and knew that there was going to be this greater distance, and they had been a lot of talk about telemedicine. So all we did is we thought about a pilot program, and it was taking this inpatient visits and making it virtual through telemedicine. And so we suggested this pilot project. And again, it got met with some, some reservation, like it's only 2.1 miles away. Why would you want to do that? I said, trust me, it's going to be good. So back in the MGH Department of Surgery, obviously us, MGH Telehealth participated, the MGPO, and then obviously Spaulding came together. And fortunately, because medicine is a bunch of silos, and we have silos within hospitals and we have silos between hospitals. And so fortunately, I have to say that all the silos came together and didn't create any obstructions to this pilot program. So we didn't have any disasters. We didn't have anybody throwing up any roadblocks, and the pilot program was allowed to go forward. And I think it was wonderful foresight by all these different silos that we have to work together and we have to make it better for the patients. And one of the hopefully wonderful things that are going to come out of the Affordable Care Act. So you got to have a team right? So we had definitely a team here prior. I mentioned Dr. Snyder had an interest in this for a long time ago. We knew that there was great care, but how could we make it better, right? And we knew that he had endorsed us coming over, and it got the Partners in Excellence Award. So we had our clinical champion with Dr. Snyder, and Jay Hefner was fabulous and continues to be a great partner with moving things forward. You had me, who was still the clinical champion, and then Ty and all the administrative support staff here. So the team was in place, and it was really just, again, changing the theme by which we were going to deliver this care. So we have the sort of high-level team, and then you got the people that actually have to do the work, right? And so the people that actually have to do the work are the people that should be acknowledged, because they're the ones that have made this program wonderful. So we got together, and I see that she's here in the audience, but we had one of the I work at the Shrine as well. The Spaulding Rehabilitation Hospital's nurse practitioner happens to be Iris, who's in the audience today. The therapists, right? The wound care specialists, and then all the other support staff, and they came up with how are we going to do this here at Spaulding, because it's easy for me, I just have to get behind a desk, but they had to physically figure out how to do this. And so we constructed an idea that we would get together once a week, happens to be on Thursday mornings at 8 o'clock, and how it works is, I think we do a lot of things that sort of just happened, but certainly are the way that I think everybody's trying to do clinic now. So we actually do a pre-huddle. So I get together with the entire team, no patients in the room, and we talk about the patients we're going to see. What are the problems? What are the issues? It's fantastic, right? Because the patient walks in the room, somebody has never left the bedside. I know everything that's going on. I know the limitations in terms of occupational therapy, physical therapy, and what questions they already have. Why don't they feel like this is great? I'm asking them all the questions they have. I said, oh, I heard that you're a little worried about your ankle. Let's take a look at that. Right? So this huddle is really important. And it also allows us to provide education. Then we do our patient evaluations. It takes about 15, 20 minutes to each patient to do it. Again, done by the staff here. And then finally, we do a debriefing. So as much as the huddle is important, debriefing, making sure we're all on the same page, and then Sam and an email usually goes out to everybody. And I think this is the fantastic thing that we're missing when we used to walk over. Now everybody's linked. So if Dr. Snyder doesn't happen to get there in the morning, he's got a summary statement of everything that was discussed and all the plans moving forward. And the entire health care team, MGH, Shrine, all the components within, Spaulding, and all the components within Spaulding have been updated. And this is where we're utilizing several forms of telecommunication, right? So we're using televideo conferencing, but then we're using email to spread that information to everybody. When we first started this program, we did a quality evaluation because we wanted to know. Remember, my partner wasn't real thrilled about it. He actually became thrilled about it. But then we also obviously want to know about the patients and their perception. And while we got outstanding reviews, I think you got to read one to understand what it says. And so this is one of our larger burns, I think 60, 70% burns, who was here at your facility for 39 days. And this is what he said. He said, I definitely feel that my virtual visits helped me get out of Spaulding at least a week earlier. For 5 to 6 appointments instead of the need of a whole day for transfer back to the MGH to see my doctor. The virtual visits took 20 minutes, and I was still able to have my occupational therapy, which I needed. The convenience of being able to stay at Spaulding and still be in contact with my MGH doctors was huge. It was just like talking to my doctors face to face. The doctor had the equipment to look at me, see my parts he needed to see, and make the decisions he needed to make to treat me. It was a great experience. I stayed connected to my doctor, and I definitely recommend it 100%. I would love to say that this is just an isolated event, but I think this is how everybody feels. And we only had one negative report, and he said, I just would really like to see, it was probably Dr. Governman, in person. Until we said, well, if you want to do that, we got to put you on an ambulance, and you go over to the MGH, you got to get off the gurney. He said, oh, no, I'll do telemedicine. So it's a little bit how you phrase the questions. But, I think in terms of what we're going for, which is patient's perception of care, home run. The other thing I want to show you is the home run with regards to real data. And so this is just a little snapshot of the program to date. So again, we've done 29 patient encounters via the virtual visiting or the video conferencing. That totaled into 73 virtual visits. We've done everything from new consults here to preoperative evaluations to postoperative visits. And really what that's done is that's avoided 73 visits back to my clinic. Now remember the metric, getting people in on time. Well, those 73 visits, which I only gave them a 20-minute time slot, being very conservative, I will tell you it's probably double that, if not triple that, when you bring it over. That gave me an extra 5 clinic days, full clinic days, and that's seeing 15 patients a day. So you can sort of see how this program starts impacting both sides of the relationship. So I opened up clinic space. I could bring in patients that needed to be seen quicker while providing the same level of care to the patients here. Now, you want to talk about cost savings to the system, ambulance traffic. So that was 148 transports that were avoided, which comes in conservatively at about $90,000 being saved just in ambulance traffic. 2.1 miles. Why we started this was the readmission, and I want to say this is unplanned readmissions, right? Because we definitely have patients that are planned to be readmitted, so I just want to make that clear because we've had patients that have been readmitted, but we knew they were going to be readmitted. But you can see the readmission rates. Do I think this is because of the once a week conferencing? No. I think it's because we've established a much tighter working relationship and people feel very comfortable emailing, calling, all sorts of communication. So that whole idea of telecommunication has just really fostered between the two groups. So I think it's just, formed that partnership. People share information and we're allowed to pick up on things much quicker. I know specifically of 2 readmissions unplanned that have been saved because of this, allowing me to come over, see the patient, do a procedure here, and not having the patient get over to the MGH. And the problem with getting to the MGH is there's inertia. And once you land in an ER, very difficult to go back because it's just not how our system is. It's a lot of inertia to get it back. Now, with regards to the MGH, we do surgical procedures while the patients are here. Sometimes as patients, I think some of them stay up to 6 months here, and we do have to do surgical procedures. And when we did surgical procedures, they used to be discharged from Spaulding, readmitted to the MGH, stay about 4 to 7 days, and then get readmitted to Spaulding. And we avoided that. Now the patients come over same-day surgery, get the surgery done, and come back, and you guys take wonderful care of our postoperative patients. So in the same 29 patients, we have increased the bed capacity at MGH by 48 bed days. So that's when we had 15 capacity alerts. We're pretty much running at 90% capacity all the time. But during that time, we were on crisis, meaning we needed beds and we didn't have them. And so you can see how this program just gave the MGH beds that otherwise wouldn't have had. And I can tell you that we had no safety and quality problems with regards to the patients coming back here after a surgical procedure. And then finally, while not important, probably the most costly thing in healthcare is people's time and the cost of that. So we saved 48 hours of us going back and forth by switching over these virtual visits. So it's not all about the MGH. I think I showed you a lot of data about the MGH and how the MGH has benefited, but I think this Spaulding has also benefited from this relationship. I definitely think that's it's increased value and has been a value add. With regards to patient satisfaction, right? I definitely feel that my virtual visits helped me get out of Spaulding a week earlier, a week less of rehab. We all know how much these patients want to get home. That's a huge investment. The other thing that these are the difficult things that you don't always, can't tangibly measure, but this is a lady who had orthopedic issues and couldn't internally rotate her hip. And so she had this ulcer on the lateral side of her ankle. that she never could see. So the significant other saw it, the physician saw it, we described it, but she never actually had been able to see her wounds. So one of the wonderful things about telemedicine is I can capture the image and actually bring the image up to the patient and show them exactly what we're working on. So all the talk when we're talking about a posterior wound, where a patient's like, I don't know, I know it hurts and I know there's something open back there, but we can actually show them visually what's going on with their wounds. And I think this is one of the value adds that you can't always capture. Business diversification. Certainly, I think Spaulding has been grown to be the regional burn rehab go-to facility. And while there are other burn centers other than ourselves, while we'd like to take care of all the burn patients, that we can't take care of all of them. And so we do get burn patients. I mean, this facility does get burn patients from the Brigham and Rhode Island Hospital. And you can just imagine that when you have a patient from Rhode Island come here, what the transport is going back to see a doctor in Rhode Island versus here. And I'm happy to report that I've actually spoken with the medical director at Rhode Island, and he feels very comfortable about allowing us to follow his patients and be in communication with him, so that we don't have to have the patients come from Spaulding all the way back down to Rhode Island Hospital, or not being seen by a surgeon because you're trying to play this delicate balance of not making people go long distances and losing out on rehab. So I think it's given a little business diversification to Spaulding, certainly improved patient outcomes. I mean, the decreased readmissions. It doesn't help Spaulding to have the patients go back to MGH. I think the other thing, and I'll show you in a second, is that we've definitely redefined the clinical care model for burns, I think, between the two institutions, and allowed you guys to be a little more efficient. I didn't do this data, so don't quote me on it, but I think the feeling here is that with this program, based on the size of burn, that we're at least saving like 3 days per patient in terms of this program that would have been lost simply because of transit time between the two facilities. And this is what I'm talking about in terms of care redesign. The old model, we did the acute care, y'all did the rehab. They'd come back and see us in clinic. We lost rehab days. If we did a reconstructive procedure, they came to our facility to recover. Sometimes you could hold a bed when you had the old hospital. Now that you're down to 123 beds, no longer holding beds unoccupied. So big problem is, you know, that 48 days that I said that I saved the MGH, that was based on a 4-day turnaround. So I think we all agree that if I said we're going to keep the patient for 4 days, the patient has to now be rescreened by Spaulding and then retransported over, and hopefully you have a bed. Pretty ambitious if we think we can get that all done in 4 days. So that 48 bed days that I gave back to the MGH, that's being very conservative. But this is the new care model. We do the acute care. You all do the rehab. The patients stay here for rehab. We don't come back to the MGH for clinic visits. We only come back for reconstructive procedures, and then the patient comes back here same day so that they can continue working the other extremities that we didn't have to put at rest because of our surgical procedure. And the great thing is that you guys have done a fantastic job here, all the support staff, nursing, doctors. We have no reservations whatsoever that you can't take care of our patients post-operatively. And I think you can talk to Iris. I don't think I've once called post-operatively to make sure that the patient was doing okay, because I knew that I would get an alert if something wasn't going okay. And I think that just goes to show how great you guys are taking care of the patients with this new care model. So the referral management we talked about, but I think definitely this population healthcare management, I think you can see how I'm very happy about this program we have, and I think the benefits to the patients as well as to the healthcare system. But I think you can see how this population healthcare management, it's actually probably going to creep into my referral management in terms of my taking care of patients in the western part of the state. Our program ourselves, we'd like to expand the program. There's a lot of licensing issues. There's definitely expansion here at Spaulding with regards to other clinical services that I'm getting asked to tell them about this program and how they can move it into various other programs, which I think would be great. We've also utilized the program to communicate with the Middle East with a program that we had, which was a safety and quality with a burn center in Qatar. All this was done with this simple technology, but I can tell you that it's not the technology that allowed this program to prosper. It was the team here. And so if I missed anybody's name, it was not intentional, and I apologize. But certainly the reason why this happened is because of all the hard work at this facility and the buy-in and all the wanting to make this happen, which really helped get this done. So I just wanted to thank you guys in terms of the facility and also the people we work with on a daily basis. And I think, with regards to Wilhelm quote, I think we definitely have established a link between the MGH and Spaulding. It's certainly collaborative. And the best thing is that the patients still get the masteries of the various services that we provide, us being the acute care burns and wound management, and you guys doing the rehabilitation. And this is why I think this is sustainable and has become now a part of how we deliver care in the Northeast. And with regards to what we want to accomplish with telemedicine, I think we've done it with regards to this program. We've done a care redesign about how we care for the patients. We've integrated care programs effectively. Certainly network development. I think, you guys are just going to get more and more burns from abroad, and I think this is a fantastic way to market that. Certainly population health management, I think we're hitting a home run. Now, obviously, I'm biased, but the healthcare savings are not inconsequential. Quality improvement, we've decreased the readmissions. Referral management, we're not utilizing patients coming over and utilizing resources of the MGH unless it's absolutely necessary, because we know that the work can be done here. And strategic planning, this is definitely how we have to move forward with the Affordable Care Act coming down and providing the best care, utilizing the least amount of healthcare dollars. So I just want to, again, thank everybody for their collaboration, and I'll be happy to answer any questions. Mm.
kind of how the finances flow, at what level ultimately those decisions get made? Is it legislative? Is it bringing insurers, third-party payers? What needs to happen?
Yeah, I think it's realization of what they're doing. So I can only speak for Arizona, and what Arizona did, and it probably had a lot to do with the physicians there and their trauma program. So what they demonstrated specifically to Blue Cross Blue Shield, I believe was the organization, don't quote me on that, what they showed is if you save a helicopter transport of a trauma patient from a facility into, I think it was Phoenix, to the level 1 trauma center, just one saving of a helicopter visit paid for the program. So, again, I think it's the level of noise. And so that's one of the things that I have to be cognizant of, is that fortunately burn injuries are not that common. But unfortunately that's a disadvantage because I'm not hitting anybody's items. Now, trauma, we know, happens every day, lots of healthcare dollars associated with it. And so I think it's very easy when you're looking at a spreadsheet, seeing the cost savings of the transport costs of moving these patients around. And so I think Arizona did a fantastic job showing that we could provide the same level of care, decrease costs to the system. And I think actually they got the third-party payers to put in these systems and for collaboration to work. I think right now, again, large volume programs, telestroke, teleradiology, telepathology, I think much easier for CFOs of hospitals to see the benefit of having that. You know, what I always run into is they say, well, how many burns did we see last year? Why do I want to invest time in doing a contract if we only saw 4 burns? So again, I think the one thing with the Affordable Care Act and population health care management is, you know, we're not going to be shifting costs, right? Everybody's going to have a play in this. So, you know, it's getting everybody not to get that silo mentality, but to work collaboratively, and that's hard. You know, this program, it worked really well. But I have to say, there were people that were, they were skeptical about was it really going to be that much benefit to the system. Yeah.
Did Arizona do their negotiating before or after they?
You know, I don't know the answer to that. I just know that they have done a very nice job moving this forward. They do a lot of work also. The Banner Healthcare System does a lot of work with tele-ICU care. So they've just, you know, I think the West has done a fantastic job with telemedicine. Although just recently, and again, I think it was one of the major insurance carriers in Louisiana put out a policy saying that they will support teleconsultation as to the same degree as they would inpatient. So again, that's huge because that's all that needs to happen. But otherwise,
Once you've developed the program, they don't have incentive to negotiate. They say, we're doing it already. So that's great.
correct, but that's the sustainability. So the problem is I think a lot of times these programs are nice, and they're, you know, they look good on paper, but then when you gotta pay for it is a whole nother thing. So, you know, you can build these programs, but you can't just maintain them for free. And so, again, trying to also capture the data, because as much as I get to look at the red boxes, right, about perceptions of care, you know, we're still in that old model that what's the dollars and what's it worth when a patient, I mean, that's a fantastic quote. What's it worth? You know, and I think we're still having struggles quantifying the perception and how much we want that to impact how we do things versus just, you know, line item budget moving forward. I do think, though, that it doesn't make it really, the studies have been done. We can provide the same level of care. Some programs, I think, are better suited for it. But for our program, I mean, there's times where I didn't get to see what I exactly wanted to see, but now I've still been able to triage. And if I come over after hours to see the patient because I just need to see the patient, it's not everyone. And it's pretty rare that I have to come over and do that.
Thank you so much.
Oh, I'm sorry.
Another question. So, what are some other limitations that you guys have been encountered not physically being able to do it, or have you had them? Well, you just kind of mentioned it about how you triage it now a little bit, so sometimes you do have to go in person. But have you run into any
Difficulties. So I think difficulties is we're surgeons, and what surgeons is surgeons in our perception of time. So I think one of the things is when you do this, and one of the things that I suggest is that there's increasing communications, which is fabulous. Time was pretty much my time, and it was a set time. And I had things blocked out for that. And I have blocked out OR time. And yes, we see patients in the emergency room, but you start telemedicine programs. All of a sudden, you know, if it's not a video conferencing, but Iris might write me an email, in the middle of the day that might not have been there with the old model. Iris would have just said, well, we'll just wait 5 days until they go over to clinic, and I'll send a note with them, and we'll wait for our response. But with the increased communication, there's increasing workload, and the thing is it's real time, right? So Iris doesn't want to wait till tomorrow to get an answer, right? So definitely, that's one of the limitations, is that, again, trying to get it. I think we're still struggling, to be honest, with when we have to come over here, because, again, and I'll take this on as our limitation is, we'll say, oh, we'll be over by 5. And then, of course, something comes up, and, again, the nursing staff has been fantastic here, but I think we're still 2 hospitals, and again, it's a time commitment to come over here. So I think we're still struggling with trying to get that communication of, if we need to come over to see the patient, is that we tell the patient when we're going to be there, because, and I personal experience, it doesn't help with patients' perception of the things. And when they said, oh, Dr. Fagan thinks he'll be over at 5 o'clock, and I show up at 9 o'clock, I'm 4 hours late. In fact, I'll tell you a funny story. I was at the door. I was coming over to take staples out one day after an operation. I got caught up at the MGH. I didn't do a great job of communicating, and I came up to the desk, and I was asking the lady at the desk which room the patient was in. Well, the significant other was at the thing and said, have you heard from Dr. Fagan? Is he going to come over today? And I said, yeah, that Dr. Fagan. You just can't trust him. And he turned around and saw me. So, these are things, though, that I think we're still working. But certainly as the program grows, I think we're learning how to deal with it better, in terms of, again, getting the patient's perception that we're providing the best and most efficient care to them.
Thank you, Shawn.
You're welcome.
All right.